We're very happy to have day one here and this panel of whom will introduce themselves to talk to us about families and youth needing to break the cycle of substance use and what their organization does for that topic. Thank you.
Well, thank you. And hi, everybody, and thanks for letting us intrude on your lunch hour this afternoon. So we're from day one. I'm Jeff. I'm here with Missy and Rich. And they're going to introduce themselves. And Terry's in the back, really importantly, our HR person. If you're interested in employment or other information about day one, please stop by the table in the back. We'd love to hear from you with any ideas or any requests that you might have. So we're going to try to present very little information to you. We're going to talk to you a little bit about day one, who we are, what we do, and I think you're going to sense through that our passion for this work that we do. But more importantly, then we're going to bring to you some ideas, some history of one of our clients that is very representative of the adolescents that we care for. And we're really going to need, and we're going to ask you to help us think through some of the things we've done, some of the things we haven't done, but really mostly get some ideas from you how we can better care for our adolescents with substance use and mental health problems going forward. So this is really going to be a working a session here. So really encourage you, and I don't think you will, not to be shy. Raise your hand. We'll go along with the mics, but we really want to hear from you. So just we'll introduce ourselves. So I'm Jeff Alberg. I'm a practicing family doc. I've been practicing medicine for about 25 years locally here. I've been at day one as their medical director for about a year or so, and I feel extremely privileged to be in that role. But I just want to say a little bit about how I got here and what I'm learning. After 25 years in practice, I delivered a lot of babies, took care of a lot of kids, well child checks, adolescents, adults, geriatrics. Somehow I missed the boat. The population that we're taking care of in these adolescents, somehow I only scratched the surface all these years. Somehow I've missed these kids. And on one hand, I kind of fault myself. Did I not ask the questions? Did I not delve into the family history, the ACEs, the adverse childhood events? What did I miss that I've now got to know dozens and dozens of kids in a short 1 year, more than I did in 25 years? What I've concluded, though, to some extent, some of it's my fault, but these kids are flying under the radar. Okay, these are not, it's hard enough getting a teenager into your practice, right, for a well child check. It's really hard getting a teenager that's living on a street, with substance use, mental health issues, a hugely traumatic background. So they're not really, we're just scratching the surface when we're in normal health care and all your professions as well. So my message to you, as it is to myself, dig deeper, think harder, ask those hard questions, and get to know who these kids are so we can all, and you'll see today, we're all going to have to work collectively to do a better job with our youth. So that's why I'm doing that, and you can see there's a lot of passion about what I do. So Missy, or Rich, you're going to say a word.
Hi, I'm Rich Abramson, the education director for day one. Full disclosure, my daughter is on the staff here at UNE, Tricia Mason. Some of you may know her through your community service learning projects. I am a retired school superintendent. 19 years as a superintendent here in Maine. My entire career has been in Maine. And for the last 18 years, I have overseen educational programs for substance abusing teens here in the state of Maine, Phoenix House, and now Day One. So I'm thrilled to be part of the leadership team at Day One and looking forward to having the opportunity of engaging you. And Missy?
So one thing I encourage folks, and when I talk to my clinical staff and others that I work with now, is that we all work with humans, and as humans, they are complex and multi-layered. So we're going to come in with our lens, and we may need other lenses of other professions to help us kind of unpack what's going on and figure out what's the best course of treatment. Behaviors are clinical gifts. So with adolescents in particular, they don't have the words to say, I'm struggling, this doesn't feel right, I don't want to do that. We're going to see behaviors. And so it's pausing to figure out what are the actions telling us they're not random, they're all connected. And so as we work through some of the case study today, it's please be creative, be curious, and challenge each other. What are you seeing? What are you thinking? And what does your discipline bring to that table in that conversation? So, are we ready? Do you have the clicker? I'm not allowed to multitask, so Jeff's going to click, and I'm going to talk just briefly about day one. How many folks in the room know what day one is or what we're about? All right. Not many. How many people have never heard about day one? All right, that's good. So day one is a fairly small agency. We've been around for about 40 years, and we specialize in adolescent substance use. Oh, look, I got it. Totally nailed it. 40 years ago, adolescent substance use was really treated out of a substance use kind of pure model. Kids that were struggling with alcohol would maybe do rehab. The last 40 years, the transition to more co-occurring work and really looking at the adolescent and the family has shifted day one's work. So now we have about 4 lines of business. We have a small residential program, which we'll talk about in a little bit. And we see kids from about age 13, which is really scary when you think about a 13-year-old needing a residential level treatment for substance use and addiction, up to about age 20, both boys and girls. And we can have about 8 to 10 kids in a house. They live with us for about 6 months. They do intensive group treatment, about 14 hours of group treatment a week. They go to school, they have individual counseling, case management, and we're really trying to figure out how to help them launch back into the world in a way that will work for them. So that's our kind of a residential program. We also have counselors, substance use counselors in the correctional setting. So we are at Long Creek and we do the substance use treatment for kids that are committed and do assessments for detained kids. And then we also run a pretty significant program up at the Mountain View Correctional Center for adult men. We do a young adult program as well as a more almost residential program for men. It's about 9 months and they live on a unit and do group treatment before they are reintroduced into the community. We also are at the Teen Center, Pueblo Street Teen Center, and we do the counseling, outreach, case management for transitioning age homeless youth. And then we have a more traditional outpatient practice that includes school-based clinicians, case management, a psychiatric provider, and outpatient therapy. Did I get them all as you were scrolling through? I think I did it. What did I miss? Who we are. Primarily, we employ, I think the vast majority of our staff are master level clinicians, so LCPC, LCSW, conditionally licensed folks. We also employ CADC or LADC level licensed professionals. We call them care associates. They're the folks that help staff our residential facilities because we're open 24/7, so almost like house parents that help kids with meals and chores, homework, following through on those pieces. Case management, we have educational providers on staff, and Rich can talk a little bit about how that works. Am I missing? Oh, we have a very new peer support specialist, which we're really excited about. So it's a former graduate from our residential program who has come back to work with us as a peer. So she's in her 20s, she gets the work, and is currently going through the training with the state to actually be a peer support person. So we are really excited. She started last week. Did I get everybody?
Rich, do you want to say a few words about the education?
We are in a number of school districts across the state of Maine. We have 8 to 10 clinical social workers working hand in hand, predominantly with high school, some with middle school age students. They work together with school guidance staff. In our residential treatment programs, which Missy talked about, the 6-month stay, so the kids don't lose out on their educational programs, we employ 2 in each of our facilities, certified teachers who work with the kids individually and in small groups and allow them to gain credits towards graduation. We have a number of students in our programs that have been with us, gotten their high set, or have completed their high school education while they're with us, and as they are completing the day one 6-month program, they transition to post-secondary programs. One of the things, and we'll talk a little bit about it when we start with the case study, school districts have a responsibility to make sure that they know where their kids are. And the case study that we'll be sharing with you today, we're talking about a young woman, a young girl, that fell off the radar screen for schools. So one of the things that we're doing with schools is talking with them about the resources that we can provide to that school district as alternatives to school suspension and expulsion. When a superintendent has to end that student's education, that's pretty serious. So what we try to do is provide them with some alternatives. So again, we're in schools, we talk with superintendents, we talk with school districts. Our education programs are funded directly from the Department of Education. Currently, we're in Bonnie Eagle and Messalonsky, 2 of the area high schools. Starting in July, we will be in Gray New Gloucester and Messalonsky High School. So we have education programs. The kids don't lose out on any of that opportunity to continue with their education in a very different setting, as you can imagine. So.
All right, I think you can, is this on now? It sounds like. And well, first, let's pause there for a minute. Any questions about who we are, what we do at all here, or hi to everybody in Biddeford? Any questions from you? Please speak up. Yes.
I actually graduated from Bonnie Eagle in 2016, so I was just wondering, like, when you guys started working at Bonnie Eagle, and whether I just completely missed, like, no one ever told me about it, or...
You may not have known. I think we were partnering with Bonnie Eagle for many, many years. Our residential programs are kind of carved out from the school, so it's a separate school building that the kids go to. It contained classroom. So a Bonnie Eagle student may not know at all that we were there.
Good question. Anybody else? All right, what we're going to do is walk through together, as you can see here, a typical client, meeting Sarah. That's not her real name, but Sarah, who I will say is more of a typical client than an atypical client that we see through day one, and someone who would enter our residential facility. It's a very recent story. It's one of those stories that you're going to look at and hear and say, well, you know, you must be making this up, or it's good that there's only one girl we see or boy that's like this. It's not true. This is more of a typical client that we see and we care for in our residential facilities. And thus to my earlier statements about how these kids are kind of flying under the radar of society in a lot of different ways, whether it's mental health, whether it's emotional, social, school-based, and you're going to see all these things come through in this story, and it's absolutely, every word is part of the true story here. So Sarah was 14 when she came to us. She had been probably 3 years using heroin daily. She had been in and out of outpatient counseling with case management. Where was she? She was up
North
more
of
remote
Bangor.
area. Yeah, and that had failed. And she had been living in different places, but mostly with her boyfriend, who was actually selling drugs for a number of years. And he was, when she came to us, he had just been arrested. The other thing, and it's not up here, that she really hadn't left the house. His house had not engaged in any social activities with anybody else for about 2 years worth of time. So this is Sarah who came to us. So I'm going to ask all of you, maybe at your tables, I'll give you a minute or two, talk about this amongst yourselves, and just would love to hear some comments from you. What do you think the next steps would be here? What other things would you need to know about Sarah or about us? And really importantly, you're in all different roles. What might you do in your role to help facilitate recovery and sustainable recovery in someone like Sarah? So I'm just going to pause for a minute or two, if you don't
I'm
mind.
just going to add
just
before you,
chat it up.
can I add something before you go? And this is for the social workers, but everyone in the room, think macro and micro. So when you think about what you know about the state of Maine and what's happened with the trends in the last few years, how is that impacting what we're seeing? And then also from Sarah as a person, how might you, again, think about the case? So kind of go big and go small as well.
So again, Sarah, a young girl, heavy heroin use, certainly all the risks that are combined with that too. What might you need to know? What would our next steps be? All right, we'd love to hear some thoughts. I'm not shy about going around and picking on people, but anybody want to offer up some questions, thoughts, next steps? Raise your hand, we'll come by with the mic. How about this table? Anyone here have any thoughts about Sarah?
Hi. We were thinking about what Sarah's roles and routines are, what her family involvement is like, how often she uses drugs, how long she's been using, how much she uses, when she uses, if there have been any other previous substances, what she likes and enjoys.
Can you just say a little bit more about what she's using and how often? Like, what would you be thinking about in that situation?
From a pharmacy perspective, it's important for us to kind of understand, sort of when this sort of use started, what led to it, if this is the only drug she's ever used, if she's used other things, and what influences factor into her use. And then also, on a daily basis, how much she's using, what that risk assessment looks like for her and her health.
Yeah. I'm going to give a cliffhanger. So she reported that she was using heroin daily. When she was drug tested at the hospital, there was no heroin in her system. Can anyone guess what might have showed up? I heard it.
Yeah, you've got it, yeah.
Fentanyl.
Yeah.
So sometimes because of the street drugs, the nature of the street drugs, kids may think they're using something and report and truly believe what they're using is that substance, and it may not be.
And when we told her this, she was very surprised. She really thought she was using heroin. So, and the fentanyl that's on the streets now, not all fentanyl is the same, and it's maybe not even fentanyl. There's other combined drugs as well. Anybody else? Any other questions? Yes.
I just think my main concern was that she's 14 and she's a minor, and she's reporting that she's been living with somebody who's 4 years her senior. Legally, she's not an adult; she's a child. So I think CPS or DHHS would have to be notified about that.
Yes, great grandma and great grandfather, who are almost 80, are her legal guardians. So that's another sort of piece.
We have a question in Biddeford, too.
Where's Biddeford?
My first thought when I read Sarah's story there was that maybe she was trafficked by this person.
Yes, there was definitely some exploitation. Her 18-year-old boyfriend is involved in a pretty significant drug run through New York with lots of criminal involvement. So muling and other things were happening to Sarah. Absolutely, and we probably only hit the tip of the iceberg.
From a medical background, I'm a PA student. I would want to do some screening for transmissible diseases, hepatitis C, HIV, potentially STD panel because of the risk for trafficking, and then discuss opioid maintenance therapy with naltrexone, buprenorphine, methadone. Fentanyl is really hard, which makes Suboxone not maybe the best option, so I think there's a lot to discuss there.
Let me flip to a little more information here. Some of you brought this up already, but you can see the family. We're thinking about here multi-generational issues, right? Sarah's dad, she never knew her father. He died before she was born from a drug overdose. Mother and grandmother both to some extent, heroin users, okay? And this is, remember, this is our more usual client. Abuse, ubiquitous in the clients we see here at a very early age, mostly from within the household. Typically we see it'll be a mother's boyfriend, stepfather, that type of thing. And then, Rich, I don't know if you want to say something about the schooling, that she had not attended school in well over 2 years. How does that happen?
Usually we get referrals from schools where kids are in attendance. Every school district across the state of Maine is required to have, it's called Positive Action Committee or Dropout Prevention Committee. So learning that Sarah had 2 years of no involvement with school really caused some concern on our part. Where was the school in trying to get DHHS involved? Where was their Positive Action Committee, Dropout Prevention Committee? Why weren't they regularly trying to get some help? And just think about missing 2+ years of school as a 15-year-old, 14-year-old.
Yeah, I would sort of add, to give some context, we at Day One take referrals from around the state, and so often we get pieces of information, and then as we kind of build trust with the family, we start to get more information. So the process we're walking you through is literally, we got a phone call and we had very limited information. By the time they were coming to an intake, we had a little bit more information, but still huge gaps. So these questions, sort of that Rich talked about, how could a 14-year-old girl kind of go missing for 2 years within the school setting? How does a 14-year-old girl who has guardians, even if they're in their 80s, live with, and I use this live with, her 18-year-old boyfriend in some sort of drug house somewhere where no one knows really where she is for long periods of time, and have no connection to the outside world in a sense, without having reports made. So we're sort of, as we start on our work, trying to unpack what we're seeing and what's going on.
So I'd love to hear we've got some ideas already, some either questions or other ideas. Does this change what you're thinking? What else should we have been or should we be paying attention to with somebody like this? Anyone?
Jeff, in the back. Wait. No. She's running. Go, Rich, go.
Can't hear me, Beneford. We were thinking about her just like cognitive and like social ability, that she hasn't been around anyone in 2 years, maybe just like addicts and her boyfriend who sells drugs. So she hasn't had any like, I'm sure any like kids or other like positive adults in her life for 2 years. That's a really long time.
Mm-hmm. Absolutely. So developmentally, what can that do to someone's sort of normal trajectory of growth? She started using heavily about age 11. She had, I think, technically died 2 or 3 times from overdose and was brought back.
3 overdoses, 1 intentional suicide attempt.
And so those normal childhood social interactions and developments weren't happening. You're absolutely right.
Just in her youth, was an ACE assessment ever done to kind of quantify her susceptibility to substance use?
We did it when she got to us, but I do not believe she came to us with any. She'd had outpatient counseling on and off for many years. And she did do a stint in Acadia. But I don't think at this point we had any of the records, and I'm not sure if they did it at that point.
Explain what ACEs is, or see if everybody knows.
Oh, who knows what ACEs is? Oh, we have a winner.
All right, 15 minutes or less.
Adverse childhood experiences, they were first defined by Vincent Fletty and Anada in a study out of Kaiser Permanente in 1986. And it was published looking at how these 10 I think they're really awesome because it's things that everyone in this room can imagine what possibly that would feel like, as opposed to what growing up impoverished or insecure housing. These are like real tangible things that we can hold on to. Anyway, the study showed that along with addiction, suicide, other cardiovascular events, where there was a dose response related to the number of ACEs that you experienced in your life and your likelihood of experiencing addiction, suicide, cardiovascular disease, obesity, hypertension, stuff like that. If you haven't read it, it's a great study. You should check it out.
Nice job.
Yeah, very, very good. And from the medical side of things, the ACEs questionnaire is rather new to us. Okay, I've learned about it over the last couple of years. It's been present in the behavioral health world, right, for decades, I think. But
Yeah, the social workers in the room will kind of resonate. So your head is hooked to your body. So things that happen to you have a direct impact on how your physical health. So the ACEs study was really putting science behind what we've known for a long time, is that when things happen to us in our world, stress and other things, there's actually changes in the body chemistry that can have long-term health effects.
And the ACEs score is basically 1 to 10. You know, you might often see 1, 2, 3 in a practice with somebody. I'd say these kids are. I mean, guess what the score would be, right? 10. It would be very high.
Yeah.
We didn't have anything on record that gave us a number about the ACEs score. So.
Right. Our average is about 8 for the kids that we bring into residential treatment.
Other comments? I just want to reemphasize what Rich said, too, about the educational part of what we do is huge, okay? Because if these kids can get back into education and have some plans for the future, after they're with us 3, 4, 5 months, they start talking about careers, their future, where they can go next. And we've actually, this spring, we had 3 girls graduate our program, all that applied to local colleges, which was just huge. They probably would. 1 or 2 of those might have been on the street instead. So the education part of it is just huge. So, all right, a little bit more. So we knew that Sarah was someone maybe we could help. I'll be honest. At first, we were wondering all these different parts that we've brought up already. You know, how could we do all this? We've been taking care of a lot of kids with many of these serious problems, but this young lady seemed to have them all wrapped into one. So we started planning how we're going to bring her into our residential facility, and you can see this. But we knew that she needed to go through detox. She may need Suboxone or other long-term pharmaceutical care, and I looked to the pharmacist to help us with this. And we were hoping that she would be cleared through a local emergency room rather quickly, so that because we can't do that in our facilities. We don't do the detox in our facilities. We're not capable. And then she would come to us. So some questions here. So these are, I'm not sure we did all these right, but I'd love you to respond to this. So she did. She was in the emergency room probably closer to 3 days rather than 2 days, but close observation, safety was there, detox happened. You know, things that we really couldn't do in our residential facility. But then the question came up, and we heard it before, I forget who said it, if it's fentanyl, is Suboxone, is that the right way to go? How do you do that in a 14-year-old or 15-year-old here? And how do we keep her really engaged in our program? A little vignette here was that on the way to the emergency room with our case manager, she was doing heroin because she was so afraid of withdrawing. Okay, she was doing it in the car on the way.
What she thought was heroin. What she thought was heroin.
What she thought was heroin. Yeah. So I'm going to pause there and look for other comments about this or about anything. Now that what should we be thinking about as she's ready to enter our facility? They're not locked facilities, okay? The kids can run, they can leave if they want to. We don't encourage that. At the last point, you know, here, how do we keep her engaged for 6 months, 6 days, whatever it is, on her road to recovery that you all know is a lifelong journey. So love to hear some comments on how best to do this.
So I think the issue of a supportive environment is really kind of a tricky one, especially with these individuals, because, well, most of us here would be pretty happy if you stuck us in a Marriott hotel and we're all in this hypoallergenic area where we had everything provided, there's coffee on the windowsill, like that would be comfortable for us. But with an individual like this, where they are in such a, they were in the same house for 2-3 years, staying in that environment, and they were closed off into that environment. So finding a new environment that is familiar enough for them to want to interact with it, but supportive enough for them to want to be a part of their own independent beneficence is really kind of challenging. That's not a simple solution. So the simple question of where do you put them is really kind of hard to answer. And I'm kind of curious as to kind of the resources that you guys have had and had success with in being able to place these individuals that encourages both of those worlds and balances them wisely. So.
Yeah, and sort of to that point, sort of adding to that, so you have someone who was really, in a sense, removed from society and isolated. Her primary support was the boyfriend who was recently arrested. Now she's back in the care of this great-grandparents who are in their 80s, and she said, yes, I'm ready to not die. So we had also a very short window of motivation where we were trying to get her connected to something and see something different. Because if that boyfriend gets out, bets are off. So we had to work pretty quickly within that window, again, to find what is a safe place. How far away from her community of origin do we have to get her to be safe? How many people can we have her around? What is a medical detox going to look like? We think there's daily heroin use. She's reporting on the way from Bangor to our facility for the intake she used. From our South Portland to Mercy ED she used. Terrified of seizures and withdrawal symptoms. So you add that. And then you have a 14-year-old who wants her slippers and her grandma. And now we're also putting her in potentially an ED hospital situation, and then potentially 6 months of residential treatment. So there's lots of factors to kind of think about in that space.
I just have a question about what you guys find in Maine. I know where I worked, the hospital in New Mexico, and I think it's fairly common across the country, don't view opioid withdrawal as needing medical detox and that people can just suffer through it on their own. Do you guys have success with Mercy and places around here willing to keep people comfortable through the process of detox?
Yeah, that is a great point.
Well, did we say she's 14, right?
She's
and
14.
non-heroin? Yeah, so,
Yes. So initially, the plan that came back to us was put her in a hotel with grandma in Portland, and then she can come back for symptom management. So what do people think of that plan? Why wouldn't that be a good idea? Anybody?
I'm pretty sure that grandma uses too.
Great grandma. So great grandma doesn't use, but she is 80 and kind of a pushover. Okay. Does that change anything? Would you still send her to a hotel with grandma to come back to the hospital daily for meds for symptom management?
I wouldn't necessarily trust her great-grandmother to make her go back or even keep an eye on her and trust her to go back. So I just wouldn't trust her with the care.
What leads you to that kind of gut feeling?
You just said she's kind of a pushover and it's already been happening.
Yeah, so yes, so great-grandma had a really hard time setting boundaries. And so the history was as soon as grandma tried, Sarah would run to the boyfriend's house. And then she just stopped coming back because grandma had rules. And no one likes rules.
I would also mention that you mentioned that she's terrified of the withdrawal symptoms, so I don't think she would like this plan either.
Yeah.
Just also, if she does have a seizure, she could aspirate and die. And her grandmother is 80, and there's not much an 80-year-old woman, especially if she's like not as mobile, could do if she's just in a hotel by herself.
let me ask if anyone has a response to the questions you asked. It was kind of a broad question, but what kind of a setting would be best for her? Someone who's probably emotionally deprived, socially deprived, nutritionally deprived, has not educationally deprived. has not learned how to develop relationships. She said to us she's never had a girlfriend. She's never been in the presence of girls, had any girls as friends. Again, she's been in this house for a couple years. So what kind of place what would be a place to have someone rehab with all those challenges?
I feel like she needs a home. That's it. Like, she needs a home. Like a house, like not a hospital, not a jail, but a house, like somewhere that she has her own bed and that she has friends and there's people there that are adults that are responsible that will take care of her because she's literally never had that.
Can I say?
You want to talk about that? So.
I was just going to say, I would ask her what she's looking for and what ideally for her does she think is best in building this new life.
Yeah, so that's a great point. She's 14, so what she wants changes about every 5 minutes. I want to live with grandma, I want to go home, I want to be healthy, I want my boyfriend back, I wish my mom was better, I never knew my dad, I want to go to school, school is too hard, I want to die, I don't want to die. Did I get them all?
Yeah, and she also, as she cleared, she's an extremely bright girl. And as she cleared, she all of a sudden started talking about what she wants to do for a job 10 years later, what she wants to be kind of when she grows up. So that process did happen. But to the home concept, Missy, you want to say a little bit about
Yes.
maybe what we do?
Totally. Yes, she needs a home. And home is really hard because she's never had a home. So it's introducing the idea and the concept of home to someone whose home has never been safe. So it's an interesting therapeutic challenge where we want to provide safe space and relationships that are healthy and a warm bed and safety. And sometimes kids fight it because that idea of that has been scary and hard before. So it's interesting in the clinical space to really figure out and tease out what is home, what should home look like, how do you introduce home in a way that's kind of paced and scoped where they can handle it.
So our two residential facilities are very close to looking like homes, right?
Yes.
They have individual beds, 3 or 4 girls or boys to a bedroom. They, kitchens. They're houses that have been modified to suit our needs, and the needs being some close observation cameras, things like that. But they're not locked facilities. But they're as close to home as we could design. I mean, the kids are required to design the meal plan for the week. Okay, they're required to clean the house, interact with each other in a way that's suitable. But you also have to remember there might be 7, 8, 9 other girls or boys there who all have similar problems. So you can see that each one of those needs their version of what that home may be. And that's one of the difficulties that we have. But Rich, I'm going to ask you to say a little bit about the education part of what they do in the homes.
One of the reasons we are here today is because we are in the process of forging a relationship with the University of New England Health Occupations and the medical school, trying to create opportunities for the kids that we're serving to provide for them another significant positive adult experience in their lives. So we have been involved and working in partnership with UNE. One of the things that we have, particularly for the boys who are on the Goodwill Hinckley campus up in Fairfield, any of the boys that complete the Day 1 program and either get their HiSET or their high school diploma can have free tuition at Kennebec Valley Community College, which is right on the same campus as the Alphon Cottage where our boys reside. So we're in the process of trying to build positive relationships with post-secondary programs such as Kennebec Valley Community College. USM has indicated an interest in working with these kids who complete their high school education and go through the detox or the 6-month program at Day 1. All of the kids, as I said earlier, are working towards getting high school credits. So when they either return or go on to post-secondary, they leave with something tangible. credits, which is important. For Sarah, not being in school, if she had been out of school for 2 years, as a 12-year-old, that's what, 6th grade, 7th grade, that she fell off the radar screen. Most of the kids that we have in the education programs are working in a very different environment than what they would find in a traditional school environment, as you can imagine. There aren't 20 kids all in a classroom. At the most, there are anywhere from 8 to 10 working with 2 teachers. So again, it's a small group experience. We have them for a short period of time. Our focus is giving them life skills. We try to equate life skills with graduation requirements, so we have a curriculum that's very diverse and very flexible. So these are the educational opportunities we try to provide.
All right, we'll move on.
Yeah, so to add to the cliffhanger, so Sarah, with some strong advocacy, was able to stay at the hospital for the weekend and do a detox and a medication stabilization, and then come to our program Monday morning where we did the transporting, because great-grandma wasn't the best at setting that boundary, and we had just gone through the detox, and so we did not want use on the way from the hospital to our facility, if we could prevent it. So here are our immediate challenges. She's 14. What is the age that most providers will go down to prescribing Suboxone? Anyone know? 16, some 15, but she's 14. So what do you do?
The recommendations are, I think, really 18.
Yes.
But we're allowed to go down to 15 with special considerations. So.
So what would you do? You have a 14-year-old daily use, heavy use, overdose multiple times, and potentially could use some medical stability. I should also report Suboxone was one of the drugs she did abuse in the community. So she also had mixed feelings about it, but did have this tremendous fear of withdrawal and seizures. Did you have a thought?
And the detox process, too. So I'd love to hear, what are your thoughts on the use of Suboxone, whether you really have a lot of knowledge or not about that?
We had to just give it to her.
But I mean, based on all her previous overdose, suicide attempts, etc., unfortunately, you know, there's no black and white in medicine, and she definitely, if you're waiting for her to fit that box, she's going to be deceased. So now's the time. If you don't act now, there may not be another chance. So, but it takes a strong provider and, you know, appropriate documentation, maybe medication, dosage adjustments, etc., close monitoring, but not giving it, no action is a worse action than making a decision.
Yeah, I mean, that's a great point, and our team really rallied around this. And why? Because I think minute to minute, hour to hour, day to day, we were afraid if we didn't do something, she was going to die. I mean, we really, that was our mantra, to get her safe into a safe place. I mean, it was a very real risk. So.
And the Suboxone was sort of a two-part challenge. We first had to find a hospital that would be willing to help with the detox, and then we needed a community prescriber.
Yeah.
With immediate access. So she was leaving a hospital Monday morning, and we needed an appointment with an addiction medicine specialist who would prescribe to a 14-year-old Monday afternoon. So what do people how do people think that went? And how might you have either thought about it, or what are some of the strategies you might come up with to sort of help that happen? Because it wasn't a choice, it had to happen.
I just asked, did the prescriber come to you, or did the prescriber require you to go to them?
Good question. We were going to make it as easy as possible for any prescriber who would be willing to talk to us. So we transported at any time that they wanted us to.
Yeah, and there's some challenges with the transport. For those of you who may know or not, Suboxone, you have an induction phase, so you start off at one level, and you have to stay very close to the client as you raise that up to get to the suitable level. So the geographical stuff, the movement, how do you get to or from, how do you have that supervision very closely in a facility that, and we haven't even touched on this, but most of our kids, heroin isn't the #1 problem, okay? It's mixed drugs, and it's very often not that, or it's opiates with something else, a lot of crystal meth, things like that. So whereas we see a lot of kids with these challenges, we don't see a lot of kids who appear to have an immediate need for Suboxone or that type of withdrawal medicine.
One of the things that I think is really important to understand and to take away from today, Jeff has been with us as medical director for a little bit more than a year. Prior to that time, Day One has not had a medical director, somebody to help with the kids that we're now seeing coming in to our facility or being referred to us for some help. There's been a real change in the dynamic with the use and abuse of substances everywhere, and we're hearing a lot about that. One of the things that this case study helps you realize is how we are working on the fly to create something that really does not exist. Having a medical director who can negotiate the medical side of what the needs of our kids are. We now have on our staff a nurse practitioner in psychiatry because the kids also have co-occurring mental health disorder. Things have changed. Day One's been around for 40 years, but the kids that we're seeing now and the level of complexity, such as Sarah presents to us, is creating a very new dynamic. And there aren't a lot of people out there really understanding this. UNE, my understanding, we will be working with Jennifer Van Dusen in the medical school that has a recent grant to help medical providers have an understanding about substance abuse and what will be facing them as doctors, PAs, nurse practitioners coming out of these facilities. So we're excited about partnering with UNE for a lot of different reasons, but the complexity of the kids that we're seeing, our ability to really be flexible enough to meet these kids' needs has changed dramatically over the 40 years that Day One's been around.
Yeah, I could just want to add to that too. So Jeff is a new addition to our Day One team, and as these kids become more and more complex, we're adding layers of mental health. I don't know if we've heard from OT, PT, or some of the other disciplines, but now that, let's pretend Sarah's now in our treatment, what could we do or offer her from your vantage point that would help in her care? If there are any of those students still here? Because we are making this up as we go, thoughtfully.
I'm from occupational therapy. So one of the questions you had on the last slide were, where do you start in keeping her present? OTs have a lot of resources for determining their interests, like an interest check sheet or an activity card sort, just things to find mutual ground for where you can take off for what she actually is passionate about would be a great place to start.
Awesome, thank you.
Great. Anyone here who's a dietitian, nutritionist? So Sarah was what, 85 pounds when she came to us? She gained 10 pounds. That's the good news. So we're gonna run out of time, but if you look at this, so Sarah stayed with us at Day One for 2 months. She went to school. She started earning high school credits, but what happened along the way, the good news was after, and someone said something about detox, she did detox and she got severely ill, nausea, vomiting, the usual things, got through that. And at first she said, I don't ever want to do that again. I'm going to stay clean and I'm going to move along. And that's when she started talking about career and that type of thing. So, and someone back there early on said, we just let people do that, right? The detox, because you don't die from a heroin detox. You can from a benzodiazepine or something like that, but not from heroin. But as she cleared, the mental health issues started to surface. And not surprisingly, with an ACE score of 8, trauma since year 1, sexual abuse, substance abuse, isolated for 2 years, it really became profound. Missy, if you want to say more about that.
Yeah, it's sort of with profiles like Sarah, it's almost a race against time. So we, in theory, removed all of her coping skills. They were substances. They were unhealthy relationships. At the same time, we're trying to rapidly build new healthy coping skills, but we're racing against those emerging mental health issues. We're putting more pressure on her. She has to attend groups. The anxiety's spiking. We're asking her to get up at a certain time and go to school. That hasn't happened in 2 years, to do a chore, to have peer interactions. So we're amping up the pressure. We've removed the coping skills, and we're trying to build new skills as fast as we can. At the same time, we have an adolescent brain that's constantly changing. We're removing substances. And again, that added stress part. So the chemistry of Sarah's brain daily is changing. And it adds a lot of different dynamics to try to figure out from a clinical perspective. Then you layer in the rest of the story. So Sarah is in our facility. Great-grandma is 3 hours away. Guess who got out of jail?
So guess where she went?
So Sarah's exit from us, there was a lot of emerging anxiety, pretty rapid mood swings. The further we got from the detox space, the more we started to see a lot of these things emerging. We had called crisis a few times. Our goal was to keep her in residential, but the medications were constantly also changing of what she needed. Was it an anti-anxiety med or what was going on for her? And her boyfriend got out of jail. And kids are tricky. Kids are crafty. So Sarah knew how to push great-grandma's buttons, and you left me here and they're not nice to me and you need to come get me, and you need to tell my boyfriend that I miss him. It starts to play, and so staff tries to sort of manage that. She ended up going to a hospital for a crisis stay. At the hospital, convinced great-grandma to come pick her up, then convinced great-grandma to bring her to her boyfriend's house. Last we knew, she's still on the run. So was this a success? What do folks think?
I mean, I think as clinicians, we need to observe that going to treatment even once can be valued as a success for her. So, yeah, no, I think it was.
It always seems to go against getting off of drugs and using substances, but did you do any education with her on harm reduction techniques, safe injection, naloxone, safe consumption before she left?
Yes, we did a lot of harm reduction. It was interesting. We thought she was coming back to us from the hospital. When great-grandmother picked her up, the hospital did not have her leave with any harm reduction strategies. So she did not leave our facility with naloxone. And she had not used heroin in 2 months and was going back to her boyfriend's house, who's actively using.
Does everyone know the concept of harm reduction? Everybody? Okay. Oh, yeah, sorry, in Biddeford. You want to talk about harm reduction, Missy?
Yeah, so harm reduction for Sarah, or really anyone who's struggling with, really anyone, look, anyone, it's figuring out willingness. So a lot of folks are not willing to give up, I'll pick on me for example, coffee. So if I want to give up coffee because I know caffeine is bad for me, or some harm reduction strategies might be, can I reduce my caffeine intake? Can I have 1 cup a day? Can I not have it after noon? What am I willing to sort of work with in that to reduce my risk of exposure, knowing full well that I'm not going to give it up completely? The tendency with providers can be like, drugs are bad, don't do them. And then your client will say, okay, I won't do them. But in reality, they are going to do them. And so it's figuring out and building that therapeutic alliance of how can I, if you are going to make these decisions, help you figure out as safe as it can be when you do it.
I just have a comment. I struggle with the fact that the grandmother, as a 14-year-old, very young minor, was still seen fit as a legal guardian. At what point, or if at any point, did you guys look into that, discuss that?
Yeah, that is also fascinating. So yes, we are mandated reporters, and so she is a minor, and she was put in our position risk. It's interesting as these cases culturally, so I'm kind of going to that macro space within Maine. Once Sarah left our care, it involved police being willing to help with a missing child. Is she a child or an adult? What is their role in that? Some police officers and departments are better at helping bring kids home, looking for the exploitation. How's that happening? Great grandma, did actually make a report to Child Protective to try to help bring her back, even though in theory it may not. We also made one as well, but trying to sort that out in a state where our Child Protective Services are kind of being redesigned because they were a little bit gutted and underfunded for a long time. So there's lots of layers to that.
One of the things that we find too often is our kids have success. Sarah spent 2 months with us, and Missy was asking, was that successful? Well, we kept her alive for 2 more months. We got some systems in place. We've got some people aware of what's going on. One of the things that we're struggling with is if the kids don't graduate or aren't old enough to graduate, 13, 14, 15 older, we're probably not going to be able in a 6-month period of time to get them a high school diploma or a high set. So what happens to those kids at the end of the 6 months? Most of the time, these kids will return to the same community, the same group of peers that got them in trouble in the first place. So we really struggle with that. Sarah was not involved in the juvenile justice system. Many of the kids that we work with are involved with the juvenile justice system, have a JCCO, a juvenile community corrections official, a probation officer, if you would, assigned to them. So we have another resource that we can work with. But at the end of a 6-month period, if they are not old enough to go to a post-secondary or work experience program, what do we do with those kids? And one of the things, and again, through the partnership that we're hoping will really blossom with UNE, is right now sitting in Augusta is a proposal to create a recovery high school. The next step for kids who aren't ready to go back to their community, the same peer group. We have put together a proposal. We're working closely with the Opioid Task Force, the Department of Corrections, Department of Education, and hopefully Department of Health and Human Services to create a recovery high school where these kids at the end of that 6 month can continue with their education, can continue with the positive supports that they were able to derive from the 6 months of group work, the education work that we've provided. So we're excited. We're hoping that that proposal, nobody has told us it's dead. It's still out there. It got a very high ranking in the prioritization that the Opioid Task Force has put together. So we're hoping that that opportunity will be there. But again, it's kind of the follow-through. Shelley, you have a question or a comment?
So right now we have some complicated issues around treatment, the providers treating people who have substance use disorders. There's a lot of stigma connected with it. There's a lot of confusion about what to prescribe, how much to prescribe, and providers feeling fearful of getting dinged. Mm-hmm. There's also special qualities, I think, that providers need to deal with clients like Sarah who are not easy. Can you speak to the qualities that these guys should be thinking about in terms of working with people like Sarah and others? And also a little bit about the culture that's out there in general around treating kids with substance use disorders.
Yeah, those are great points. I think, started my introduction with Sarah. All the people that we see are human. So we work with humans, and humans are not perfect. No one in this room is perfect. Sarah is not perfect. And so I think sometimes we get scared with the behaviors that we see, and we lose the compassion for the reasons why we're seeing the behaviors. Sarah, I think Rich had said that she was not involved in the criminal justice system because she was an 80-pound, adorable blonde, very sweet. You could have put those same behaviors that she was exhibiting in a 15-year-old boy, and he would have been at Long Creek because of the drug trafficking and the muling and the different things that she was doing in the community that were actually illegal. So I think for us, it's really being thoughtful on what are our biases, what are we seeing, can we not, and even the language that we use. I think that's another one that I challenge my clinicians. These kids are bad, they're doing criminal things. No, let's get curious. What are the behaviors? What are the clinical gifts that they're showing us? And then it's our job as professionals to kind of sit together and work together and try to figure out how do we best support them as humans with that compassionate space. These are hard cases, and it's often, I think, easy when we're tired and we're working really fast to start to blame. Well, if the mom did a better job, or if grandma could hold boundaries, and so now we've lost our compassion for grandma because she can't do it right. But grandma's a human too. Great-grandma. Great-grandma lost her daughter and her granddaughter, and now her great-granddaughter to substances. She's been battling with these multi-generational challenges for 60-plus years. She's tired. And so how do we have compassion for her as well, and how we talk about her and her family and her struggles? So I don't know if that answered kind of your question. I got off on my tangent, but...
The other thing I think about is kind of the next generation, okay? So Sarah was not on birth control, right? What are the chances that she is going to pass this generational issue along to if she has a child going forward? So I guess I'm in this business, not, well, I've given up trying to save the world, but if I can save a couple of these adolescents and the next generation, I think that's the place we need to work, is to work upstream there. But if we don't work with the families, or whatever the family unit is described as, again, we're at a loss, because these kids are going to go back to from whence they came. So it's bigger than any one particular client. So if to be driven by that, I think, multi-generational challenge here that is huge, and it's more than just having Narcan when somebody overdoses. It's really how do we stop this process from happening in our environment, for generation after generation.
And for everyone here, you will have a professional identity, and you have one piece of the puzzle. For kids and families, there's lots of pieces that have to sort of fit together in order to have success. So without housing, stable housing, Sarah's not going to make it. Without education, Sarah's not going to make it. Without appropriate medical care, Sarah's not going to make it. Without clinical resources and a good recovery plan, Sarah's not going to make it. Without family therapy and family supports, Sarah's not going to make it. So as you think about your treatment planning and your interactions with adolescents and families, it's figuring out what are the pieces that you know, and then what are the pieces that your peers can be very helpful with, and not being afraid to reach out to them. It's one thing, I've been doing this for almost 20 years now. The complexity, I don't know if it's getting more complex, or I'm just more aware of the complexity because I'm becoming more aware of the complexity. But with these cases, these are not things that you can solve, individually. You need case management, education, OT, PT, probably even some speech stuff. The whole gamut Sarah's going to need in order to be successful.
Yeah, and I try to spend a fair amount of time in their group sessions. Sometimes I'll go in with the idea, well, let's talk about nutrition, let's talk about physical activity, let's talk about sleep, let's talk about just over-the-counter medicine. most of these kids don't know anything about any of that. So there's an opportunity for many, many, many different disciplines to come in and help these kids in many, many different ways. So I think everything you all do, no matter what your profession is, these kids are really needy, and we can use your help. Up till now, we haven't been doing a lot of that prevention. We've been really stressing the recovery side of things, the mental health side of things, but they've got this other whole large batch of challenges that, because they haven't been brought up in a society that stresses that. These kids don't know what's good to eat. From pharmacy, a question I get all the time is, how much marijuana is too much marijuana? Or what over-the-counter medicine does this or does that? They just don't know. So there's opportunity for everyone, from certainly the clinical behavioral health to the nutritional, exercise, sleep, you name it. It's all of need.
And I just want to pick up on that. And again, the quality metric that we use oftentimes are the kids successful in completing that 6-month program. Did they come in, stay with us for 6 months, gain some skills? From the educational metric, did we give them 5, 6, 7, 8 additional credits that they can go back to their local high school? Did we help them get their high set, formerly the GED? Did they complete? Did we help them move on to a post-secondary experience? So again, Shelley, some of those are metrics that we do try to take a look at. And we have successes. Jeff talked about the fact that last year, 3 of our girls who ended the school year went on to post-secondary experiences. That's successful. But again, and I think as we began the conversation with UNE, having recovery programs available where kids who are going to post-secondary, what supports are in place on those college campuses across the country to support those kids who came and overcame substance issues but now need that support as they're facing that new point in time. You brought up a point, the occupational therapy. As we sat with UNE and talked about this recovery high school, we thought about all of the wonderful opportunities that could exist to creating service learning, community service, internship opportunities. And I just want to take a moment to talk a little bit about some of those. OT could certainly be instrumental in working with these kids. Physical therapy. Some of these kids haven't been very actively involved physically. Pharmacology. We're facing some very new challenges and trying to have a better understanding of what recovery medication, medically assisted treatment. All of these things are just starting on the home front. So here's another opportunity. We talked about a dietitian and nutrition. Think about, if you ask the kids what they want to eat, pizza, subs, hot dogs, hamburgers, they're not thinking about nutrition. So here's an opportunity to not only work with the kids, but work with the staff. Have the kids do some cooking lessons involving that. The nurse practitioners, the physician's assistants, the dentist. These kids probably haven't seen a dentist much of their lives. So there's just some wonderful opportunities that we were hoping that we might pique some interest, both here on the Portland campus as well as the Biddeford campus, creating opportunities for you to get down and dirty, working with our kids, and creating another significant adult. We began the conversation with a club as part of the medical school. Everybody that goes into the medical school, the osteopathic school in Biddeford, selects a club or activity that they want to be involved with. We've begun that conversation with the medical school, so they are thinking about coming up, taking the kids on hikes. If you think about what we have available at Goodwill Hinckley, miles of trails, athletic fields, lots of unique opportunities. So we're hoping that you would think about that. Terry Welch is here from day one. She's got some business cards. You can take our card. You can reach out to us if you are interested in exploring an opportunity. There's some literature. Do we have a sign-up sheet back there too? Terry's not going to let you out the door unless you sign up for something. But we also are hoping that we've piqued some interest on your part, that these are activities that you would like to explore. So we're here and we'll continue on, but I wanted to share that with you.
The other thing I would just add to sort of here's my pitch, advocacy and stigma. So if I asked folks in the room if you know someone who is struggling with substances, I'm going to guess unless you were lying, everyone's going to raise their hands. So this is a challenge that we face regardless of who you are. It's all socioeconomic backgrounds. I mean, it's happening everywhere. We also, in this state, have struggled for a long time funding programs that can make a difference in people's lives. So has anyone ever heard of HCT? It's a evidence-based home and community treatment program. Last funding increases were, I think, 2005. So if you think about what bread costs in 2005, and those are the same reimbursement rates that we have now. So right now in our state, we have counties that have no HCT providers. So Sarah, discharging from our program, would have benefited from some in-home treatment. There are hundreds of kids on wait lists within parts of our state that will be on the wait list for years and will be adults, and their kids will need HCT before they actually get the service that they need. So when you think about your role as advocating for what we need, it's appropriate funding, it's figuring out how to work in an integrated team, it's how do you pay for the services that these kids need, even if it doesn't fit in a nice, neat treatment box in a 60-minute session, 1 hour a week. So, some things are funded, some things are not, and it's our job as the health community to really advocate, and both, again, on a micro level for our patients and our clients, but also at a macro level to let the state know what we need.
Missy, just a word, I know a stay at Long Creek, I think on average costs about $250,000 per client per year. How do we fund our kids at the residential facilities? Where does that funding come from?
So it's a mix of funding, and it's completely underfunded. Our residential rates were, I think, done in 2008. So again, a loaf of bread. We are funded through main care reimbursement for treatment aspects, so it's a double funding, and then through SAMS with a block grant for the housing component. The funding was created back when kids came to residential programs for alcohol use disorder. There wasn't the influx of crystal meth and fentanyl and heroin. There wasn't the explosion of social media where now a drug runner from New York can find a 14-year-old girl in Maine within 5 minutes and start exploiting her in that space using different apps and social media. All of those things didn't exist when we did our contract negotiations many years ago. So when you think about the challenges that we're now trying to undo with the kids, we're not funded to be able to manage these things.
And educationally, the funding is provided by the Department of Education for all of the kids in our residential treatment program. Each year, I put together a budget and submit that to the Department of Education to cover the educational component of what the kids need. Keep in mind that a number of our kids also have special education needs. We didn't talk about that, but they struggled in school, got involved in substance, and now we find them on our doorstep. So the educational funding is provided directly to our programs to cover their costs. And there's an incentive, it's unique to the state of Maine, but there's an incentive to the two school districts we work with, that even though those 18 to 24 kids that we serve in our programs don't cross the threshold of their high school, those two school districts get to count those kids as if they were resident students at Mezzalonsky or this year Bonnie Eagle High School. So those two school districts derive a benefit. And that's why we have such strong partnerships with those schools, because they see the benefit of what we're providing and the struggles we go through. So I think you have main care that covers a lot of the clinical costs. We get a grant for the housing proponent. component of the program, and then we get the education funding for those kids. So again, what everybody's trying to do is to keep the kids engaged and the funding for them.
I would say, we also look for United Way funding and other funding streams. It's a constant struggle. The funding sources are fragmented. And so when you think about families and kids, we've got funding coming from Department of Corrections, Department of Ed, SAMS, Maine Care, United Way, other private grants. It becomes a pretty complex picture pretty quick. Last plug, interns, social workers. Hey, see me later.
We're about out of time. Anyone have any closing comments, questions, thoughts? Surprise, surprise, right?
So the ACEs study that we talked about is really important. One of the things it left out was protective factors and resilience factors. And I think, my opinion is that ACEs lead to erosion of those, lead to not having ways to cope with this, and then lead to substance abuse. So substance use, what do you guys as an organization do to help rebuild resilience and protective factors in your kids?
Yeah, that's a great question. We talked a little bit about some of the positive adults, and exposure to just pro-social exercises or activities. We've gone to what's the baseball in Portland? Sea Dogs. So bringing kids to a Sea Dogs game, bringing kids, we went ice fishing, just having more normal developmental activities can be very helpful. The positive grown-up is the hard one. I'll just give an example. We had 8 girls at our house over Christmas time, and we wanted to invite a parent to bake cookies. We were 0 for 8 in being able to invite a parent to our home with the girls to bake cookies because of the restraining orders, the lost custody, the active use of that generation. So building resiliency, it's how do we start to develop healthy adult role models in the peer space or, again, volunteer space. They have huge impacts. Some of the healthiest relationships our kids have, which is sad and great, is with their JCCOs, because they may be the longest relationship that they've had that is stable, where someone's holding them accountable with some boundaries and not giving up on them no matter what. And how do we replicate that for those kids?
But also in our group sessions, a theme there that's repeated over and over is around resiliency. And again, they have 14 hours a group plus their own individual counseling every week. So yeah, you're right. It's a huge part of where we need to go. Just one last thing. I think we have to wrap up. In my practice with adults, some of my adult patients have been with me for decades, and we never seem to be able to get well. Now that I'm a little more informed about the ACEs, and now as I look back towards their childhood, these are grown-ups that never had their ACEs and their ACE scores and their trauma of early years tended to. So now, 20, 30, 40, 50 years later, we see that they continue to struggle as adults. So we're not only helping the kids, we're helping these kids to be more functional grown-ups at a later time. So I think we need to close. Are we out of time? And thank you all.
Thank you all very much. Thank you. These guys are on the front lines of a difficult situation. I think for myself, my takeaway is if you're screening for substance use disorders, how old did you have to start to screen Sarah? When she was 10 or 11, right? 8. We needed to be screening early. So it's very important for those of you who are expert student leaders, screening is key, and also that recovery is possible. There are many resources around the state and country working on recovery. Recovery is possible, and it's interesting to think about having anything that you do, think about recovery as being in the room with you. Who are those people, and what is their story? And that helps us to be very human-centric in our behaviors. So thanks very much for staying. Thank you, Biddeford, for being here and for asking questions, and we'll see you in a couple of weeks.